Welcome, everyone. Thank you for joining us. Our webinar today is entitled Utilizing Nutritional Testing in Pain Management. Our guest speaker is Dr. Elizabeth Board. My name is Dr. Lenore Powell. I'm a medical education specialist in Genova's Atlanta branch, and I will serve as your moderator for today's webinar. We would like to welcome Dr. Elizabeth Board. Dr. Board is a board-certified anesthesiologist and pain medicine physician who currently practices non-narcotic pain management, acupuncture, and functional medicine full-time. She was the second MD to be certified by the Institute of Functional Medicine in Georgia and is a frequent facilitator for IFM. Dr. Board has extensive teaching experience, including prior faculty positions at Emory University School of Medicine and Stanford University School of Medicine in California. For the second year, she is teaching military physicians through the Department of Defense and IFM. She is the founder of Atlanta Functional Medicine, a clinic in Alpharetta, Georgia, where she collaborates with a group of talented functional medicine practitioners to seek the root cause of chronic disease and dysfunction and create personalized treatment plans for a variety of health concerns. The presentation is currently available to download. You can actually access it under the Handouts tab on the GoToWebinar toolbar. Simply click the link and the download process will begin. In addition, you will have access to the presentation and the slide deck on our website within a few weeks after the webinar. You can access these resources, previous webinar recordings, brief video modules, and other materials by clicking the Clinicians tab on the home page. I'm going to turn over the role of presenter to Dr. Elizabeth Board.
Okay, I'm going to get started now. So the objectives for this presentation are to identify specific nutrients which benefit common and also challenging pain conditions. What we want to do is see if we can preemptively do an assessment on a patient and find out what they might be missing, and what they're missing may actually help us understand how to help them by repleting those specific nutrients. So as you go through this lecture, I want you to kind of pay attention to different conditions and different nutrients. We're going to go through nutrients first, and then we'll go to some specific conditions. I'm going to have to move pretty quickly, and so if you do find some information that you want to dive a little deeper into or review, notice that on the upper left-hand corner, all of the slides are numbered. So just jot those numbers down for your own personal index. When I go over the research, it's going to be recent research, it's going to be human-based studies, unless I indicate it's an animal study. So this is the most recent human studies that I could find on nutrients. And so why would we assess nutrients in pain patients? Well, it turns out that more than 70,000 Americans died from illicit and prescription drug overdoses in 2017. And the National Institute for Drug Abuse actually tells us now, at least back in 2015, that 1 out of 3 Americans used opiates for pain, and that's a really high number. In 2007 to 2014, the pregnancy drug dependency rate rose 511%. And what that means also is that the babies that are born to those mothers actually go through what's called neonatal abstinence syndrome, and those costs have gone up from actually 61 million to over, they've gone up by 4 times, over $300 million, and not to mention the morbidity that those children go through. A large percentage of accidents are now being related to opioid impaired driving, and so even if you don't use opiates or you don't prescribe opiates to your patients, it turns out that you are at risk to the opiate epidemic now. Luckily, there's a pressure to shift away from the reliance of opiates onto more comprehensive pain management. And this Heather Tick article down below, which you can actually download for free from the internet, is a very extensive article with lots of research sources looking at that very notion of moving toward comprehensive pain management and really sort of inspiring physicians and organizations to do more research. And that's one of the problems. Nutrient studies for pain conditions is really sparse because there's not a big financial gain in doing studies on magnesium, for example. But the 3 most common conditions that can be quite costly because of the sheer number of patients who suffer from them are low back pain, knee osteoarthritis, and headaches. Now, I always say that man's ability to handle pain is grossly underrated. And if you think about it, we are born into pain from the first time a woman gives birth. And if you think about it, the first sound that we make, the first sound that we use to communicate is actually a cry. So we've been having pain since time began, and yet we haven't had opiates to our disposal. We haven't, many groups of people don't even drink alcohol. If you think of the Pilgrims, and in this case, the Mormons, this is a statue of the Mormons pulling hand carts over the Rocky Mountains. It's really the interaction of what resides within us, which is our own physiology, and something from the outside world, whether that outside world is coming from nutrients or from relationships. But something has allowed us to manage and conquer acute and chronic pain. And when you think about that notion, it becomes much more interesting to when you think about the fact that we have this interaction set up from the get-go. So let's find out what the NIH says. So the NIH actually says that the environmental factors in the outside world actually are powerful enough to change the phenotypic expression of our genetics. And we call those epigenetic changes. And they included micronutrient deficiencies, which I thought was quite interesting and really powerful. So the NutrEval, which Genova can do for you, actually can help you knock out one of these major epigenetic changes. And it doesn't always mean that you're going to give a patient supplements. It may be that you're going to give them supplements in the beginning and then sort of teach them how to eat better so they can get what they need. One of the cases we'll go through is a 70-year-old woman who has cervicalgia, and she had 2 falls, underwent cortisone injections without benefit, and eventually her neurosurgeon looked at her x-rays and said, I think you just have rheumatoid arthritis. But all of her rheumatologic studies were negative. She had a history of being treated with multiple antibiotics, so that may have impacted her body's ability in her gut microbiome. She was eating organic and minimal meat, so she did have a practically vegan diet. And you can see she's on some supplements. So my plan originally, whenever I have patients on a lot of supplements, is I will often just put them on an anti-inflammatory diet, an elimination diet, and do some routine labs. I don't tend to over-prescribe supplements unless I have data to tell me which supplements a patient needs. And again, that's what's great about the NutrEval. This patient had mild inflammation. She had a great vitamin D. CoQ10 was relatively adequate, but she had a major methylation deficiency. Her iron levels looked pretty good. Is this enough information? Is this enough for us to prescribe a plan and to help this patient? Is she at risk for nutrient deficiencies? She's not on a lot of medications, but we know she has a restricted diet, and she's had some gut changes from all the antibiotics she's been through, and she's also been on steroids, and she's also been in chronic pain. Which nutrients might have efficacy for her? So stay tuned. We're going to answer those questions in this talk. Let's jump into alpha lipoic acid. So this is information about alpha lipoic acid, which many of us don't hear a lot about, but it's actually made in animals normally, and it's absolutely essential for aerobic metabolism. When you think about pain, you want to be thinking about mitochondrial health. That is sort of the organelle that has so much to do with nerve health, tissue repair, and pain. And alpha lipoic acid is essential in that mechanism. Now, it turns out that alpha lipoic acid in some countries is actually considered a pharmaceutical drug, and it is also manufactured as a dietary supplement in this country. The body can produce alpha lipoic acid, but it can also be absorbed from the diet. And this is what's interesting about it. It's not huge dosage that most people need, because even doses as low as 200 milligrams can provide up to 1,000 times what an individual would get from their regular diet. And then this also gives some information about how you should administer alpha lipoic acid and when the peak levels are reached. So what about the research? It turns out that alpha lipoic acid with an aldose reductase inhibitor, which is a drug that's used to manage diabetes, that combination therapy was superior to the drug itself or to alpha lipoic acid alone. And it didn't just help pain, it also improved nerve conduction velocities in patients with diabetic peripheral neuropathy. So this is the first example of many, many examples that shows how a nutrient and a drug can work synergistically for a greater effect for our patients. And this is another study looking at diabetic peripheral neuropathy. And in this case, they combined methylcobalamine, which is, of course, B12, along with alpha lipoic acid and Lyrica to find that there was a significant improvement in pain and also improvement in sleep interference. And we know that's so important for people that are in chronic pain. Most chronic pain patients have sleep interference and fatigue, and they're going to need to get a good night's sleep to recover from pain. Now, we also see benefits of alpha lipoic acid in low back pain and sciatic neuropathy, and we found that this alpha lipoic acid helped as part of a multimodal approach. What you're going to find in a lot of this research is it's not one nutrient that improves everything. It's a nutrient in addition to other nutrients or to other medications sometimes that help the patient recover from pain to a very significant extent. the body is more of a symphony and not so much a soloist. We don't think of nutrients as a soloist, but more part of the symphony. Patients that have endometriosis were actually improved with N-acetylcysteine, alpha-lipoic acid, and bromelain. And this is another study looking at patients who had vestibulodynia, which is a horrible condition of chronic pelvic pain, and painful bladder syndrome. You probably have patients that have this and have complained about it, and you didn't really know what to do. I didn't until these studies. And it turns out that alpha-lipoic acid and omega-3 fatty acids can be added to a low-dose amitriptyline, also known as Elavil, and get significant outcomes. It also allows the individuals to lower the amount of amitriptyline. And that's one of the things we want to do in the opioid epidemic. Anything that we can do to augment and to lower some of our dependence on medication is definitely a positive outcome. There's another study I'll talk about in a moment, which is on endometriosis. So what about omega-3 fatty acids? So omega-3 fatty acids are obviously associated with reduced pro-inflammatory prostaglandins. We've known this for a long time. And in this study, it was actually 2.7 grams a day that reduced NSAID use in rheumatoid arthritis patients. And again, osteoarthritis knee patients have been able to show a benefit when they have improved omega-3 ratios. In fact, in this study, it showed that there was a significant concern in patients that have high omega-6 and omega-3 ratios. That is a concern for increased pain. So again, this is a condition or a situation where you might want to replete a patient when you see that they have low omega-3s so that they don't develop an exacerbation or further osteoarthritic pain in other parts of the body as well. This is a study looking at rheumatoid arthritis, and it was found that the use of fish oils was very helpful there. This is another study using fish oil with Elavil for the prophylaxis of migraine attacks. And this is the study I was telling you about before, when they actually did surveys looking at patients that had sort of a non-favorable omega-6 to omega-3 ratio. They found that that was directly related to unacceptable pain relief and refractory pain. And these were a group of patients on methotrexate. So when you're doing a NutrEval, you will get a very explicit and detailed report of not just omega-6s and omega-3s, but also omega-9s. So increasing the omega-3 level and reducing the omega-6s actually reduced chronic headaches and also improved quality of life. What about vitamin C? Well, vitamin C is a safe and very effective adjunctive therapy for lots of different acute and chronic pain conditions. And if you think about scurvy, which is when we discovered that one of the reasons why vitamin C is so important, the original description was not just poor wound healing, but actually sore arms and legs, plus a lot of muscle and joint aches. Humans lack the enzyme as well as a couple of other types of creatures like other particularly primates. They lack the ability to make vitamin C, and so we have to get vitamin C from our environment, although some cultures that eat raw meat can get vitamin C from raw meat. So you can tell your patients to either eat some oranges and some lemons or eat some raw meat. So this is a study looking at 3 grams of IV vitamin C, which actually reduced post-op pain in UPP surgery, and I will tell you that's one of the most painful surgeries, being an ex-anesthesiologist. And vitamin C was also helpful in chronic venous disease. It was helpful in post-herpetic neuropathy. In fact, there's a lot of studies showing IV levels of vitamin C can be very helpful in patients that have shingles. There was a reduction in post-surgical CRPS. So CRPS is chronic regional pain syndrome, which is an incredibly difficult chronic condition to treat. And what they did in these studies is they gave patients IV vitamin C prior to the surgery and found that there was a significant reduction in wrist and ankle surgeries, which are surgeries that put patients at high risk for post-surgical CRPS. Oral vitamin C also reduced osteoarthritis and actually decreased the NSAIDs by 1/2. And vitamin C is also helpful in cancer-related pain, in the quality of life. It did, however, not necessarily in this case, lower opiate requirements. This is a great review article by Nabizdik down there, and you'll see at the bottom right corner is the citation, and he actually goes through some of the reasons why vitamin C is so powerful, all the multiple actions, in addition to wound healing, but also endothelial function, immune function, and antioxidants. And these are some organic lemons, which you'll see are absolutely full of juice. These are lemons that were not bought at the grocery store, but were grown in a garden, and you can see that they have a much thinner outer layer and they're full of juice, so we like organics. Vitamin D has been known to help chronic pain sufferers and correlates with muscle fatigue factors. A rapid dose of vitamin D actually can improve sunburn and improve epidermal damage. Vitamin D also can help PMS and dysmenorrhea, and this is a study looking at 50,000 IUs given once a week for 9 weeks, and at that point they could see an improvement. Vitamin D was used in this study to analyze chronic pain in agricultural workers, and they found that in certain areas where the workers were had low vitamin D, improving that actually improved their pain. Vitamin D is superior to placebo in reducing migraine in migraine patients. It is one of the nutrients that's been found very depleted in burning mouth syndrome, which is very difficult to treat. And in this study, we found overall, and it is a big meta-analysis, and in 19 randomized controlled trials, they found that vitamin D improved chronic pain. This is a study looking at fibromyalgia, and I'm sure all of you have had a fibromyalgia patient before, but it revealed that vitamin D supplementation was able to reduce pain scores and improve pain, even though in the VAS, which is a visual analog scale, which I don't, even as a pain physician, board certified pain physician, I don't use it that much, but it's what we have used to try to quantify pain. Overall, the patient still improved, regardless of what that scale was. It really just kind of speaks to how poor the scale is. Vitamin D has been inversely related to painful manifestations such as fibromyalgia. These are all separate studies kind of telling the same thing. And what I want to tell you about here is that vitamin D also helped with sleep hygiene, which again is so important in chronic pain. I can't begin to tell you that when you're looking at these nutrients, think about which of those nutrients also help sleep, because that is going to also improve the patient's pain. This is just a brief case example that I had of a patient who was 48-year-old male, who was now disabled, unable to really do much of anything, had chronic widespread pain. And when we tested him, he had a vitamin D level of 15. So we started him on a high dose initially and then a maintenance dose thereafter. We also placed him on low dose naltrexone. When he came back to me in 2 months, literally all of his pain resolved. The only thing he complained about was the LDN and the side effects. So I weaned him off the low dose naltrexone over about 3 weeks, and I just spoke to him on Monday, and his pain has not returned. And we made a decision that if the pain returned, we could go back to the low-dose naltrexone, but at least at this time, it looks like it was just the repletion of the vitamin D and being on an anti-inflammatory diet that completely reduced his widespread pain. What about magnesium? We love our magnesium. Magnesium is actually been found to slow the flow of calcium from one nerve to the next nerve through the NMDA channel. So it's actually an NMDA receptor blocker. And so it can work, I think of it as a natural pain reliever, not just for neuropathic pain, but all types of pain. This is a study in animals showing that when you use magnesium with opiates, you reduce the opioid requirement. There have been studies in migraines, including menstrual migraines, that show improvement in headaches with magnesium. And this was an interesting study looking at the intra-articular injection during knee arthroscopy and found that there was improved pain relief and even maybe more importantly, chondrocyte protection. IV magnesium, like the vitamin C we talked about before, actually has been able to improve CRPS. This was a case report of a patient who had severe CRPS, and after the IV magnesium, it improved her pain. Intra-op magnesium is now being used in the OR, and it's used to reduce post-op pain requirements, agitation, and reduce PACU stay. And these are all, when you think about this, pretty amazing that mainstream medicine would be willing to hang a magnesium drip. But we've got to do something about the opioid epidemic, which of course has opened the eyes and the minds of a lot of pain and anesthesiologists. In chronic myofascial pain, this study showed that zinc and selenium tended to be low, and the patients also tended to eat less foods that have high zinc and selenium. And they suggested that this was probably because the inflammatory state itself required more zinc and selenium. But remember, zinc and selenium are very important for antioxidant reduction, and more we're seeing that we need to improve antioxidant, or we have to increase our antioxidants in addition to our anti-inflammatories. They work together to decrease pain. This was a combination product, and what's amazing about it is it was lycopene, EGCG from green tea, selenium, and zinc. So there wasn't it wasn't a major anti-inflammatory, and yet it increased or improved inflammatory parameters, improved progressive sperm motility and sperm morphology. So it wasn't necessarily an anti-inflammatory, but it was a combination of antioxidants. There was pain reduction in that study as well. What about the B vitamins? These are the B vitamins if you've forgotten the names of them. B vitamins are water soluble. They lack toxicity except perhaps B6. So we do need to be careful about B6, and that's another great reason to do a NutrEval, is because you want to find out from a patient, do they even need B6? I am hoping there will be more and more complex B supplements that lower the B6 level, because I have seen more and more patients who have had B6 toxicity. B6 toxicity is very severe. It's difficult to improve the nerve damage that occurs. We think that that happens because B6 is, when it's not phosphorylated, it decreases the absorption of phosphorylated B6, and excess B6 can cause the same symptoms as a lack of B6, and we're talking about peripheral neuropathy. All of the B vitamins in general are particularly found in meat, but also in vegetables. So when you have patients that are vegetarians, make sure that they're getting their B vitamins from these particular foods, or do a NutrEval and find out which Bs they need to replete. Increased consumption of beer and other alcoholic beverages do result in a net deficit of most B vitamins, so you want to be aware of that in the patient's history and replete accordingly. Now, there are many examples of nutrients augmenting pain relief, and for example, this is an oral B complex, which was given to patients that are on Voltaren or diclofenac, and they found that there was an overall improvement in pain beyond what diclofenac could do alone. And this again is an animal study showing that a B12 combined with other pain medications such as NSAIDs and opiates improved pain as well, and that really recommended that we want to do more clinical trials looking at B12. And so this is the concept, one of the big concepts I want you to get from this talk, which is a nutrient with a medication will give an augmented benefit. But it could also be that the nutrient plus other nutrients can give an augmented benefit as well. Let's look at B1. So B1 has been able to improve symptoms of fibromyalgia, and this was in a study where they actually looked at the levels before and after. Another study looking at chronic joint, back, and muscle pain was improved using B1 and a 5-herb blend. So again, a lot of the combination products are where we get our most significant benefits. This is a case report of a patient who had chronic cluster headaches. These are so severe that people often kill themselves when they can't get past a chronic cluster headache. And in this particular individual who had a 26-year history, they started him with 250 milligrams. They increased it every 3 days, and he was able to become symptom-free after taking high-dose B1. This is a 66-year-old patient who had a case report of trigeminal neuralgia, and in this particular condition, she was already on Tegretol, not a high dose, but a relatively low dose of Tegretol, and also given B1 and B12, and this improved her symptoms successfully as well. So think of the B vitamins as augmenting current medications, and in the case of the thiamine, perhaps even working alone. You'll find that B1 is also low in burning mouth syndrome. B2 has been known to be helpful for migraines for many years, and there are 2 actual medications now, Migravent in Germany and Dolovent in the USA, which is a combination magnesium, CoQ10, and B2 that has a significant impact on migraine frequency. And again, we've talked about the burning mouth syndrome. This was a study looking at 659 patients, and they found that in patients with this condition, the most common depletions were in vitamin D, B2, B1, B6, and zinc. So in those patients, think about doing a NutrEval and repleting what you need. I can't guarantee that it will improve the condition, but it is a place to start. Let's look at B6. We mentioned before, B6 can cause a problem. The symptoms can become devastating in the form of peripheral neuropathy, painful peripheral neuropathy, if you exceed certain levels. And I try to keep my patients under 100 milligrams, but a NutrEval, again, is a great way to find out just how much a patient needs. And the richest sources of B6 actually are found in organ meats and certain vegetables like potatoes and fruit. So when you do a patient's nutrition history, you can also start to guess where they might be deficient. In the United States, it turns out that most of the B6 comes from fortified cereal. So when you take people, a lot of people are going grain-free, then you want to dive a little deeper to make sure they're getting it. But 75% of B6 from a mixed diet is bioavailable, and I think that's one reason why a lot of people are taking high doses of B6. They may not actually need them. Think about doing a NutrEval. B12 has been shown to be beneficial for many nerve conditions, and as you know, it's one of the first places we go when people have peripheral neuropathy. The reason for that is because B12 has a proclivity for neural tissue, so it's going to help regenerate nerves, and not just in axonal growth, but also in the Schwann cell differentiation. And this is can be life-changing for patients who've had severe nerve injuries. This is a study that looks at B12 upregulating BDNF, the big nerve, which is the brain, which is so important, and also increasing nerve conduction velocity. It can be deficient in patients who do not have enough stomach acid because maybe they're on a PPI, or they have exocrine pancreatic deficiency. These are also concerns that will be spelled out in a NutrEval as well. So nerve damage related to B12 deficiency appears to be a direct result of the myelin sheath not being protected through methylation. And of course, when you have degeneration of the myelin sheath, you can have nerve destruction. I included this table from Busing's study down here in Pain Physician. Now, this is a very recent article. It's a review article in 2019, and they looked at the benefits of B12 in multiple studies. And you can see compressive neuralgia, chemotherapeutic induced peripheral neuropathy, diabetic neuropathy, herpetic neuralgia, low back pain, and aphthous stomatitis. And very significant improvements. MCB stands for methylated cobalamine. So there are 20 different genetic abnormalities that could not allow your body to absorb B12 into the tissues. And the most important tissue, or the most important organelle in addition to the nerves, would be the mitochondria. So think about that when you look at a B12 level. A serum B12 level might look really good, but it doesn't mean that the patient's getting the B12 that they need. The NutrEval will help you with this, because the NutrEval is going to look at the need for B12, not so much just the level. And so that first bullet point is so important to understand. That's why your patients who have good B12 levels get better when you give them more B12. It could be because they need a higher dose to try to override those genetic abnormalities. So B12 alleviates pains in diabetic neuropathy, low back pain, and neuralgia. And it can improve nerve conduction. Small fiber neuropathy is associated with B12 deficiency, and we talked about some of the other ones that were listed in the spreadsheet that I showed you earlier. This is a patient who had fibromyalgia. He was a college baseball player. He had migraines, insomnia, peripheral neuropathy. He was on multiple medications, and he was eating the SAD diet with a lot of sugar binges. And so we know that sugar acts as a diuretic and could even be depleting us of our Bs even faster. Now, this is his history of what he's been through in his lifetime. And while he was started off as a college athlete, because of all the injuries he's had and all the surgeries, he's a very talented coach, but has chronic pain. He's now on tramadol, 100 milligrams TID, and that was not even controlling his pain. So we did his original lab testing and found that he had some inflammation, but a very low vitamin D, a very high homocysteine, which could indeed be due to a lack of B2, B6, B9, and B12, and there's his B12, which was actually low. His CoQ10 is borderline low, and then of course he's got a fasting glucose from eating that terrible or SAD diet. His omega-3 index is also low. And so these are all nutrients we've been reading about and how important they are. He also had some, on his stool test, he had some issues there. This is what his NutrEval looked like. But what we ended up doing for him is going ahead and giving him changing his diet, but also going ahead and giving him fish oil, vitamin D, CoQ10, magnesium, and a good B complex with B12. And we also had him work with a health coach. In just 3 weeks, he had cut his tramadol to 50% of what he'd been on. And remember, he was in pain on the higher dose. He was now off the Ambien. He had increased energy. His bowel movements were more regular, probably because he was no longer on the tramadol and was eating a better diet. He had only had one migraine, and incidentally, this is an individual who was having migraines every single week, usually 2 or 3. His family came with him and actually reported that his mood was better, and he'd already lost 11 pounds. And now he was only complaining about pain when he was throwing pitches, so he was able to get back and be fully engaged in his work as a coach. And we talked about CoQ10, giving him CoQ10. Well, CoQ10 has been helpful in fibromyalgia patients. And I like to include his story because he is a male sort of stud, right? I mean, he's an athlete, he's a coach, and he had fibromyalgia. He was diagnosed with fibromyalgia. CoQ10, if you look at this comes from the study below from Frontiers in Physiology in 2018, and actually shows the dark arrows show what has been demonstrated efficacious for CoQ10. And look at that, mitochondrial deficiency and inflammation. And the dotted lines show the efficacy in evaluation, which includes neurodegenerative diseases and a lot of other things there too. So CoQ10 is really important for pain. L-carnitine although in the Genova, you will not, in the NutrEval, you will not get a recommendation for L-carnitine. I'm going to show you in the NutrEval where you can see that where L-carnitine is needed. And it's really important for knee osteoarthritis as well as peripheral neuropathic pain and muscle pain recovery in athletes. And I'm going to show you, you need this to be able to get your free fatty acids into the citric acid cycle to be used as energy. It turns out that 25% of the L-carnitine can be made endogenously, but get this, 75% must be consumed. And the main source is meat. So many people have given up meat, they are at risk for L-carnitine deficiency. And that might include a patient that we just talked about earlier, the woman with the neck pain. So this is a big study, a very extensive study looking at branched chain amino acids, and it was sort of a plus-minus study. So I encourage you to look at that study to learn more about it. I still think branched chain amino acids are a good idea, but in this study, it really had mixed results. Certain conditions like chronic pancreatitis and endometriosis really improve from antioxidants. And so I want you to look at this funnel and don't forget about it. Think about antioxidants kind of working together to overall decrease oxidative stress, which in the end will help with inflammation and pain. Remember that the mitochondria hates oxidative stress. So when you can reduce oxidative stress, you improve the mitochondria. When you improve the mitochondria, you can improve pain and healing. So pain patients that are at risk for nutrient deficiencies are going to be anybody with gut dysfunction, anybody with malabsorption. TMJ will not allow patients to consume healthy foods. They have been shown to have significant nutrient deficiencies and chronic pain. Alcoholism as well, causing axonal neuropathy, and carnitine deficiencies leading to muscle aching and weakness. We just talked about why carnitine is so important. Chronic kidney disease as well. And then patients that are anorexic or have orthorexia, where they start to deplete large food groups from their diet, they're going to have nutrient deficiencies. It's going to set them up for chronic pain. We talked again about chronic liver and kidney disease, don't produce enough L-carnitine. Athletes with spinal cord injuries, if you do, this second article is a fantastic article on that, looking at all the deficiencies found in spinal cord injury patients, and they already suffer from pain, so you could actually make an impact on them. And think about medications as engaging in nutrient thievery. So I've listed from a research article, which is actually it's a review article looking at lots of different drugs and what they found got depleted when patients were taking them. And you can see them listed there. But what I use is this one. This is a culmination of a lot of information I've looked at over the years, and I use this. And I've color-coded them to show you how certain nutrients like CoQ10, the B vitamins, vitamin D, zinc, how many drugs actually deplete you of the same nutrient. And you will have patients in your office who are on not just one of these drugs, but multiple drugs. And you can see how at risk they are. And all of the most of the nutrients I've listed here, particularly the color-coded ones, are absolutely required for mitochondrial health. So the mitochondria is the source of energy for every cell, and these are drugs that literally have the ability to rob the raw materials that we need for energy production and pain relief. These are specific pain conditions benefited by nutrients. I'm going to go pretty quickly through these, so jot the numbers in the upper left-hand slide area. So supplementation of lipoic acid as well as omega-3s tend to help chronic postpartum pain, and chronic pelvic pain could be helped again with this palmitoyl ethanolamide and alpha-lipoic acid. They didn't see significance until the 6th and 9th month, and this is a randomized placebo-controlled trial looking at antioxidants, vitamin C and E, and found that pelvic pain and endometriosis improved. This is one of my patients who was a male and had selenium and zinc deficiencies. You can see the selenium and zinc lines on his nails, and this is a very quick and easy thing to look for with patients. And patients that have selenium and zinc deficiencies are at higher risk for chronic myofascial pain. In this study below, the last study below shows you that piriformis syndrome can actually be benefited by giving B vitamins and mannitol. Burning mouth syndrome, I alluded to this earlier. These are many of the nutrients that are deficient in burning mouth syndrome, whether this is a lack of being able to eat them or whether it is actually the cause of burning mouth syndrome was not clear. But it's a great place to start with repletion. It did turn out that when they used alpha-lipoic acid with gabapentin, they did see an improvement in patients with burning mouth syndrome. In fibromyalgia, we talked about CoQ10, and fibromyalgia, think about anything that improves the mitochondria could possibly help fibromyalgia. And this is a study looking at CoQ10. It also found, interestingly enough, that it helped fatigue and sleep disturbance. There's B1. We know B1 is one of the unsung heroes of the bee world, but very important in bringing nutrients into the citric acid cycle. And this is a study looking at amino acids as well as magnesium, selenium, B, and D, as well as checking out the harmful effects of heavy metals and finding that muscle pain was associated with those. And so talking about mercury, I have a patient later on that shows a mercury causing severe headaches. The beautiful thing about the NutrEval is they will study both all of these, mercury, cadmium, lead, arsenic. These are all mitochondrial poisons, which means they are possibly going to cause chronic pain. And this is a study that proved that. In small fiber neuropathy, in this study where they looked at a large number of patients that had it, they looked for commonalities and found that actually B12 was a deficiency that was found in a fair percentage of patients. The most significant one, of course, is going to be immunology. This is difficult to change, but we can work on diabetes and sugar intolerance, but these are actually sodium channel mutations, but B12 is a reasonable place to start. And in fact, this pilot study, separate study, showed that B12 deficiency caused symptomatic as well as asymptomatic small fiber loss. So again, this is where we could preemptively analyze a patient and maybe prevent a damaging concern later on, which is actually very difficult to treat. The NutrEval can help you with that. So in tendon injuries, it turns out that amino acids, vitamin C and D, manganese, copper, and zinc are helpful in improving tendon growth and healing. This is actually some eggplant that I made that looks a lot like mitochondria, and it should, because it actually has a lot of the nutrients found in eggplant actually helps the mitochondria. Form follows function, I guess. In TMJ, this is a study looking at multiple nutrients that are deficient in those patients, and other clinical findings were found, also in poor skin healing as well as hair loss, cheiliosis. So in general, when we can't chew our food, we're at risk for the very nutrients we need to heal. Migraines, prophylactic treatment for migraine includes riboflavin. We talked about that. And then this is a combination treatment looking at butterbur, riboflavin, CoQ10, and magnesium. And then there's also evidence that supports magnesium, carnitine, riboflavin, and alpha-lipoic acid. The separate study looking at migraine. So you might want to jot down page 50 or slide 52 if you're dealing with migraine and review your patients. Chronic tension headaches can be helpful when vitamin D is repleted. So these are studies actually looking at children that had chronic tension headaches, and they found that many of the children had low vitamin D, and the lower the vitamin D, the more likely they had musculoskeletal pain and tension headaches. This is a randomized placebo-controlled double-blind crossover trial. So if anybody tells you there are no studies, this is one right here, looking at, unfortunately, a low number of children, only 14, but it did have a value of significance, and they found that for this particular children with this type of headache, that they found the benefit of riboflavin at only 50 milligrams. There's really no side effects from riboflavin generally either. It's not like B6. And so when you're working with chronic pain patients, ask yourself, could this patient be missing nutrients? Could it be because of the vegan diet that they're on? Could it be because they're on a standard American diet? Could they have TMJ, mouth pain, dental loss, or maybe their dentures don't work anymore because they're losing weight? Look at eating disorders, and don't forget about medication that engages in nutrient thievery. So I'm going to run through some patient cases and we'll be finished. So this is the patient we introduced earlier, and we would say we probably don't have enough information, and so we ended up doing a NutrEval for her. If you recall, these are some of the findings we found in our standard labs, but the NutrEval actually showed us what we might have expected. So she had significant B deficiencies. She had that low alpha-lipoic acid, which we now know is so helpful for chronic pain, particularly neurologic type pain, and also vitamin C. And when you look at her study, when you look at her citric acid cycle, one of the things I want to point out is that she really needed L-carnitine. So we don't give you a recommended daily allowance of L-carnitine in the Genova NutrEval, but you can judge that she's going to need it because her adipic acid is high and her sudoric acid is also slightly high. So we wanted to make sure that we gave her L-carnitine, particularly if you review what I've gone over, L-carnitine can help in chronic pain. So, and let me go back and look at this too. If you notice, she's missing a lot of amino acids. I don't think this is entirely because she's vegan. I think she probably has a maldigestion component, and the NutrEval will also suggest this. You get so much information from the NutrEval, not just your nutrients. And we know that in some cases, the amino acids can help in chronic pain. So for her, we treated her malabsorption, which was part of her root cause, and we stressed the importance of getting protein in. We increased her CoQ10. Although she had a reasonable number, we went ahead and pushed it up higher, increased her magnesium, increased all her omegas, and also improved her B vitamins. She was taking a sublingual B12, but it may not have been high quality. So we went ahead and gave her B12, gave her a product that has acetyl L-carnitine, alpha-lipoic acid, and antioxidants. A wonderful product that I use, and it kind of has it all. It's really designed for the mitochondria. And in 2 months, she came back and sat in my office, and I can remember it as if it was yesterday. And she looked at me, and we went over some other things we were working on, and she said, "Where is my neck pain? It's gone." And we didn't treat her with any medications. So don't forget about the care and feeding of the mitochondria. The mitochondria doesn't like this. This is the care of the mitochondria. They don't like these things. They like lots of this, but remember, it's moderate exercise, not excessive exercise, because that causes oxidative stress. And they like some of the center. You don't want too much of those things. Too much iron can be a mitochondrial toxin, as well as manganese can. My second patient is a patient with arthritis who was treated with PRP injections by her orthopedist, but he wasn't getting the results he wanted, so he sent her to me. You can see she's at risk for medication nutrient thievery, and so we might expect some of her nutrients to be low. She's taking a Zantac, which may impact her absorption. And in her, she was low in B vitamins. And I do find that patients that are in chronic pain tend to have low B vitamins, just like patients that are under stress or patients that are on ADHD medications. When you run that citric acid cycle hard, you're going to burn through those Bs faster. And so what we ended up doing with her is we did replete her of those nutrients. But let me show you her. She had a lot of oxidative stress going on. She was deficient. Actually, her nutrients looked pretty good, so she wasn't very deficient in her nutrients, but she had a high mercury level. And so we decided to go ahead and treat that as well. So this is the bonus that you get when you're working with patients that have a NutrEval. You're going to get a lot of information on not just nutrients, but also gut and toxicities. So we repleted her nutrients, we gave her B vitamins, and we gave her mitochondrial support. We increased her selenium, and to help her get rid of the high mercury, which selenium is important for that. And what was so beautiful about this is her orthopedic surgeon actually came to my office to thank me because, once we did all these things, she did improve, and she's been on no opiates and no NSAIDs since then. So again, using a surgical this is in a case of a surgical procedure along with nutritional repletion. This is a patient with chronic lumbar pain and headaches. She came to me to help prevent Alzheimer's disease, but we did a thorough evaluation and found she had these concerns as well. We put her, we did a NutrEval for her. She was already taking magnesium, but sort of a okay vitamin D, kind of a low CoQ10. We know how important CoQ10 is, and she was iron deficient. In her NutrEval, she showed a big deficiency here in her Bs, and lots of minerals were deficient. So when I see a lot of mineral deficiencies, I worry about absorption. Does she have enough hydrochloric acid? If she doesn't have enough hydrochloric acid, she may not, or digestive enzymes, she may not be absorbing proteins. And so when you see this, the very next page on your NutrEval is going to show your amino acids. And so I wasn't surprised to see this low as well. So we're going to work on giving her hydrochloric acid and pepsin. We also gave her other nutrients that she was kind of low in, including zinc. We improved her iron, which isn't listed here, but in mainstream medicine, it's easy to get an iron. We improved her B vitamins and her magnesium. And she, in 6 weeks, her headaches had completely resolved. She was sleeping well, her energy improved, and she was eventually able to exercise without back pain. And in 10 weeks, she was headache-free. The last case is an interesting case of a patient with severe migraines, insomnia, and excessive thirst. And her myeloperoxidase in her conventional labs was incredibly high. It was so high I retested it with a different lab company, and at that time it was also high as well. Just a very high homocysteine and some damage to the kidney. This level should be about 0.6 to 0.8. And her CoQ10 was real low. So of course we're going to probably replete her CoQ10. But we did do a NutrEval. And like we talked about, when we have a lot of oxidative stress, it's damaging to the mitochondria. If the mitochondria can't do their job, they're going to be putting her at risk for chronic pain. She needed lots of Bs. She needed also a lot of minerals. When we see the mineral deficiency, we worry that she might need hydrochloric acid. But what really was the most dramatic was the high mercury. Now, why might we have thought she had high mercury? She had a really high oxidative stress marker. Something was going on, and it all started to make sense. She also had low selenium. So it's not a good combination to have low selenium and high mercury, because you need the selenium for the metalloproteinases to help your body detox. So of course, in what we did with her, I'll stop quickly to say that mercury toxicity can cause headache pain in addition to a lot of other concerns, and that comes from a research article. But for her, we put her on we put her on organic unprocessed food. We gave her high dose CoQ10. We did give her a fairly high dose of selenium. We gave her a detoxification medical food that was proven to remove mercury. And with that, she had, at 6 weeks, she was no longer having headaches. She was sleeping better, and exercise wasn't bothering her as much either. She had much more energy. So to summarize, let me say that nutrient testing can improve pain relief by identifying deficient nutrients necessary not just for inflammation, but also for oxidative stress, and that we want to provide the essential nutrients for repair of nerves and other tissues when we're talking about the long game or the end game in taking away pain. Those nutrients can also decrease pain signaling, and magnesium, for example, is an example of that. Identifying nutrient deficiencies early on can increase compliance. So in patients that don't want to take supplements or don't want to change their diet, when you show them their NutrEval, they're going to be more compliant. And I could give you the coach that I worked with as a case in point. And then also the diet doesn't always have to be supplement based. So nutrient repletion can be done alone in the case of a couple of cases where it was just one nutrient that improved, but mostly nutrients work real well in combination with other nutrients or in the combination with medications. We do know that more research is needed, and until then, though, we can use nutrients and food as medicine because the risk-benefit ratio is so much more favorable than the use of opiates or the use of NSAIDs. So as my last shot, I want you, if you do nothing else, I want you to start thinking about two things. Always ask, is there something about this patient that could be causing a nutrient deficiency? And the other piece is, could repletion of that particular nutrient or another nutrient improve this patient's pain or tissue repair? And if you really wanted to know, precisely and really personalize the care to the patient, then you may want to do something like a NutrEval. And I'm finished. Thank you.
Thank you so much, Dr. Bort. That was a great presentation. Hopefully the listeners have a bunch of notes like I do. We have a few clinical questions, so let's go ahead and start with this one. What form of magnesium do we find the best results with regarding improving pain?
So what I do with magnesium does so many different things that I always like to question the patient, and if a patient is constipated and could use a little help there, and some of the chronic patients will, because they're under stress, and that increases the sympathetic nervous system so that they're not be able to engage in parasympathetic and have bowel movements. And bowel movements are important for toxin reduction. So it's the last step. So when you think about it, it's very important. I like to use magnesium glycinate in that case. If the patient has a lot of constipation, I'll use magnesium citrate. Magnesium citrate, magnesium glycinate are very well absorbed. The other, if I have a patient who has diarrhea and I'm worried they won't be able to take enough magnesium glycinate because that magnesium is going to give them worse diarrhea, then I will use magnesium aspartate. There are other forms like threonate, which I haven't used as much, but I've had great results with those three, and I really base it on what the bowel movements are like. And sometimes I'll tell patients you may want to use magnesium aspartate and have some citrate on hand for the times when you become constipated. Patients can change back and forth. I will say glycinate has glycine in it. So when you're doing a NutrEval, if you find that a patient has low glycine levels, we know glycine is one of the 3 amino acids that makes glutathione, which is essential for oxidative stress reduction. You could leverage that and say, we're going to give you magnesium glycinate because you need glycine and magnesium.
Regarding B6 toxicity, do we see that more with the pyridoxine HCl or the P5P pyridoxal 5-phosphate form of B6?
That's a great question, and it's the unphosphorylated. So we really don't see that with the P5P. In everything that I've studied and read about, because I have had patients present with a neuropathy due to B6, everything I can find says the P5P is the safer form. Now, and it's actually in the article, if you go back and look at the article on that particular slide, you can look at that research article and they'll talk more about it. But what they say is that the regular pyridoxine hydrochloride is the one that it limits the absorption in the body's use of P5P, and it's the P5P that is the bioavailable one that you really need. And so then we start to wonder, maybe it's the overabundance of the regular pyridoxine, not phosphorylated, that is reducing the P5P, because certainly sometimes the symptoms of B6 toxicity looks like B6 deficiency. So I hope you followed that. If you're taking regular B6, it could limit the absorption of the phosphorylated form, and the phosphorylated form is the part that's so important for reducing nerve damage.
And regarding the maximum B6 dosage that you typically use of 100 milligrams, is that for the non-phosphorylated form of B6 then?
That would be for the non-phosphorylated, but after working with patients and how devastated they were from that, I'm really trying to even keep that under 50. So an easy rule of thumb would be 100 for just about anyone. And use your NutrEval, because if you have a patient that's on, let's say, 80 to 100 of P5P, for example, or a combination of P5P and P6, if you add up all the B6 that they're taking, when you do your NutrEval, if you still see a B6 deficiency, then at that point I would take them off of B6 and put them only on P5P. But I would still keep the dose below 100.
I have two questions regarding which supplements were you referring to precisely? The combo mitochondrial supplement used in the first case study with B vitamins, acetyl-CoA, alpha-lipoic acid, and antioxidants. What was that supplement?
So I use orthomolecular, it's called MitoCore. And one of the nice things about that supplement, while it does have pyridoxine, it doesn't have the phosphorylated form, it only has 15 milligrams. So if I could change the product, I might add the phosphorylated form, but it is only 15 milligrams. The downside on that supplement is you do take 4 a day, but they have a new product now that is a powder. So you can ask a patient to take the recommended dose, which I think is 1 scoop of the powder, put it in water and sip it throughout the day, and they'll get what they need in addition to amino acids. So that's the new one, it's the powdered form of MitoCore. But the supplement MitoCore is 4 capsules a day. The only thing it's missing is CoQ10. But it has alpha-lipoic acid, it has N-acetylcysteine, it has green tea or EGCG, it has broccoli seed extract. So it has all what I call the care of the mitochondria, all the antioxidants, but then it has all the raw materials the mitochondria needs as well, which is your B vitamins, L-carnitine, alpha-lipoic acid, some magnesium, some reasonable amount of magnesium, vitamin C, vitamin A, everything else the cell needs. I will tell you there's one other company that has a pretty good one too. Designs for Health has, it's called mitochondrial Mito NRG. Now that one actually has CoQ10 in it, but it may be missing 1 or 2 of the other nutrients. So.
And just really quickly before we wrap up the webinar, you mentioned the detox medical food used to help remove mercury. If you could list that for us, please.
So I use, Metagenics has, it's called Ultra Clear Renew, and it has been studied to remove not just mercury, but other heavy metals. Now remember, lead is actually lost more through stool. So sometimes the lead, that's where you really want to work on your GI, your elimination that way. But as far as arsenic and mercury and other heavy metals, I love the Ultra Clear Renew. Now, in my experience, when I've had patients have really high levels of mercury, it has always worked. And I dose the patient based on how high that level is. If it's someone who has a very high level, like the patient you saw before, they're going to need to take that shake on a regular basis and maybe go through several canisters. But when I have tested patients, I usually have them go through at least 2 canisters. I like them to go on good omega-3s, clean omega-3s. It's almost like you're doing an oil change. You're getting rid of any mercury that might be there with clean, non-mercury containing fish oil. You're making sure they have plenty of selenium and using the medical food. When I've retested them, Lenore, the mercury levels have dropped significantly, and they really don't have any side effects. So I haven't had to put anybody through some kind of IV chelation, which can be safe in the right hands, but we haven't really had to do it in our practice.
Wonderful. In the interest of time, we will end our question and answer period there. For additional education materials, we'd like to encourage you to visit our website, www.gdx.net, and or contact client services. We also offer complimentary appointments with our medical education specialist to answer questions related to our testing, including choosing the right test and reviewing patient test results as well. Finally, we'd like to encourage you to register for our upcoming webinars on www.gdx.net. Next month, we will have Dr. Christine Stubbe presenting on parasitology, stool diagnostics from basics to blastocystis, and several dynamic speakers and topics to follow in the upcoming months. Dr. Board, thank you so much. That was a great presentation. I want to thank everybody for being so patient with us as we navigated through our IT challenges today. But I hope you all have enjoyed this beautiful, wonderful presentation. Again, thank you, Dr. Board.
Thank you.